Hello, everyone. Welcome to the Audio Learner. This is the very first video. The Audio Learner is meant for the learner that requires auditory learning. So, if you are the type of person that likes to listen to things while you are doing other things, such as driving, and you want to make your environment into a classroom, then this is the channel for you. This is going to be my very first video in order to help me study for my dental hygiene course of periodontics. And so we are going to get into the study guide for the final exam for the periodontal class of final study guide. Okay, so the concepts to know and review before getting into the topics are: make sure that you know how to calculate cal. If their gingival margin goes apically below the CEJ or above, if it's maxillary, then you are going to be calculating cal by adding the pocket depth and the recession. So that's addition. Now, you can also calculate cal if the CEJ rises up coronally. The margin, the gingival margin rises coronally. In that case, you're going to be subtracting. Okay, so if there is legitimate recession, you're going to be adding the pocket depth plus the millimeters of recession. So two readings in millimeters added together with recession will give you the cal. And also you can get cal, but this time there is no recession. It's the opposite of recession, but you will be adding the pocket depth. You will not be adding the pocket. You'll be subtracting the amount of addition of gum above the CEJ. So that means that you're subtracting. Okay, moving forward. Make sure you know what a furcations are. Class 1 furcation, the neighbor's probe can enter into the furcation about 1 millimeter horizontally. You still cannot see it clinically. Class 2, the neighbor's probe, slight radiographic lucency, but the neighbor's probe can go into a furcation for more than 1 millimeter. A class 3, there is a definite radiographic lucency, but not clinically. And then class 4 means that you can visually see the furcation. All right, so also know what a UNC periodontal probe is. That's the one with the tiniest markings that mark 1 millimeter, 2 millimeters, 3 millimeters, 4. And then the marquee is the one that we usually use. That's 3, 6, 9, 12. Okay, some more review here. Make sure you know the stages of plaque biofilm formation. Stage 1 is going to be pellicle formation, which forms within minutes after cleaning teeth, is composed of salivary glycoproteins, protects enamel from acidic activity. Salivary proteins and peptides promote bacterial adhesion through specific receptor mechanisms. Stage 2 is bacterial colonization of the pellicle. This is where bacteria adhere to pellicle via specific receptors. There's gram-positive aerobic bacteria that are present, mostly streptococci. These organisms form microcolonies of cocci, which form colonies that extend out from the pellicle. So stratified layers against the tooth surface. Stage 3, here is bacterial growth and maturation. So bacteria secrete extracellular polysaccharides to form an insoluble water matrix. Biofilm increases in mass and thickness, and lipopolysaccharides, or LPS, form from gram-negative cell wall is present. Bacterial coaggregation, certain bacteria here to previously attached cells in plaque biofilm. Okay, so moving on, extending in this is that the filament-shaped bacteria become coated with cocci, forming a corn cob appearance. Cool. Early colonizers are streptococci, actinomyces, and late colonizers are fusobacteria, rods, and spirochetes. more gram-negative, anaerobic, motile, and asaccharolytic. Great. All right, so got that out the way. Now let's get into the juice of what this final is going to be about. So we're going to start with systemic and local delivery antibiotics and enzyme therapies and irrigations. I started with locally delivered antibiotics. We're going to call these LDAs. And I started there because um, that's kind of what is the most important thing to learn from all this. So let's go. LDAs, locally delivered antibiotics. We have Arrestin, which is 1 milligram spheres of minocycline, a form of tetracycline. You have Perio, which is chlorhexidine, which degrades in 10 days and does not stain. We have Atridox, which is doxycycline, another form of tetracycline. And then we have Elizol, which is basically metronidazole. Now, what are the advantages of locally delivered antibiotics? Well, the first two are, the only two, are that low concentrations of a drug. So that means that there is a lower risk of systemic effects. The other one is its active ingredients are at high concentration at the site of infection. So that's two advantages there. Indications for LDAs, which are localized, recurrent, or residual pocket depths of 5 millimeters or greater with inflammation or BOP after SRP treatment, usually at sites that don't respond to treatment. That would be an indication. Now, contraindications are multiple sites in one quadrant with pocket depths of 5 millimeters or greater. So multiple sites, not just one. LDA was already used and no improvements were found. And also anatomical defects such as infrabony defects or vertical radiographic defects. So those are contraindications. Some other contraindications are acute periodontal abscesses, or if people have a tetracycline allergy, which includes doxycycline and minocycline. Tetracycline derived LDAs are not to be used on pregnant people and children under 8 years old, specifically during tooth development years. Here we go with more information. So there is not enough data to conclude that LDAs can reduce the need for SRP surgeries. More data is needed. Studies limited to 9 months. Basically, not much difference in pocket depths with proper SRP treatment. Okay, so that was LDAs. Now we're going to go into systemic antibiotics. So we just finished talking about things like Arrestin, things we put on teeth directly or near teeth directly in pockets. Now we're going to talk about systemic antibiotics. So the first one to know is tetracycline. The three things to know about tetracycline is, and when I talk about systemic antibiotics, these are used in conjunction with traditional therapies. So tetracycline is why it's good for periodontitis is because it's concentrated in the gingival fluid. It's helpful in treatment of grade C progression, and it inhibits collagenase activity. So, and also Agrigobacter, which is a species of bacteria, is also susceptible. So I think the most important thing from tetracycline is that it inhibits collagenase activity. Next, we have metronidazole. So metronidazole, three things we need to know about that is that it inhibits the red complex bacteria. And the way I remember red complex bacteria is, please go take Freddy to dinner, which is PG, TF, TD. So P. gingivalis, T. forsythia, and T. denticola. Please go take Freddy to dinner. That's how I remember that. So metronidazole inhibits that, and metronidazole treats grade C periodontitis. And metronidazole, when it is combined with amoxicillin, studies show that it works well. Now we're going to go into penicillin, which is also amoxicillin. It's not useful alone because it does not benefit attachment and pathogens can become resistant. Bacteria produces enzymes that break it down. That's how bacteria get resistant to penicillin or other antibiotics, by producing enzymes that break it down. When it is combined, though, with clindamycin, it treats refractory progressive periodontitis. However, it is still under investigation. So penicillin combined with clindamycin treats refractory progressive periodontitis, but is still under investigation. So what are the advantages of systemic antibiotics? So multiple sites can attack multiple sites by reducing pathogens in other parts of the oral cavity, the entire mouth, and reducing risk of recolonization. Now, what are the disadvantages? Three of them. Uncertain patient compliance. Some people do not continue taking them as they are recommended. The inability to reach high concentrations in the gingival curvicular fluid. And the other one is increased risk of resistance and adverse drug reactions. So those are the three disadvantages. Now, let's look at the patients. For who is this type of therapy good for? So we have patients with continuous loss of attachment after therapy, so recurrent or refractory. Either it's their fault or it's not. That's the difference between recurrent and refractory. Side note, recurrent means that they did all the therapies and surgeries and they're just not maintaining the oral hygiene, or they're not coming in to get seen. And so if it comes back, that's recurrent. Refractory is that they're doing everything that they're supposed to and they're still getting periodontitis. Anyways, moving forward. So patients for who is this therapy good for? The systemic antibiotics. It's people who also have grade C periodontitis. So the rapidly progressing type. And then the acute crazy types, necrotizing types, which are NUG and NUP, and periodontal abscesses. So, and then the other ones are indications for chronic periodontitis. Those are controversial. So just to review, who are the patients, what type of patients is this good for? People with recurrent or refractory periodontitis, grade C perio, and acute necrotizing gingivitis periodontitis, ulcerative gingivitis, and ulcerative periodontitis. So nugging up. Those are the patients that systemic antibiotics are good for. Also, if they have periodontal abscesses. Okay, so that was systemic antibiotics. Now we're going to go into enzyme suppression therapy. So these are enzymes released by the inflammatory response of plaque. And again, these are also kind of like systemic antibiotics because they do have to be prescribed at a specific dose, except that they stimulate enzymes released by the inflammatory process. So not necessarily the systemic, which is made to kill all the bacteria that's bad in your system. This is just to kind of trigger enzymes released by the inflammatory response. So we have two types of doses. We have an antibacterial dose, which is high enough to kill bacteria. You have a sub-antibacterial dose, low and not high enough to kill bacteria. The first one we're going to talk about is called Periostat. Periostat is doxycycline. It's a host modulating agent. It is also systemic. And so Periostats, the sub-antibacterial dose is 20 milligrams, and the antibacterial dose is 50 to 100 milligrams. It's used for chronic periodontitis patients, and it's used 2 times daily for 3 months. Studies are good with low doses, but studies not longer than 12 months. So another thing about Periostat is that it reduces collagenase activity in the gingival curvicular fluid in adult periodontitis. Now, the AAP position is only for periodontitis and not anything else. That's doxycycline. Next one is NSAIDs. So aspirin, ibuprofen, naproxen, nonsteroidal anti-inflammatories. These reduce tissue inflammation by inhibiting prostaglandins and osteoclast activity, association with slowing rate of alveolar bone loss over 3 years. However, this messes up your stomach. You can get ulcers, and they can also cause kidney and liver problems. So, and they're not approved for perio treatment. So these are not really your best bet. And for periodontal disease, other ones you have statins, which are cholesterol reducing drugs. There is some protection against inflammation, still not used for periodontal disease. Then it's your nutrition. You have omega-3 fatty acids that resolvins have been shown to prevent bone loss in animals. But I think there's also enough evidence on omega-3 that it's also generally good for you in other ways. Now we're going to be talking about irrigations, so which are usually done after non-surgical periodontal therapies. So the three most important things to know about irrigation is you have to reach the site of disease at the base of the pocket, be used at bactericidal concentrations, and it must be substantive, meaning that it's able to retain and stay in the area. So those are the three most important things. Reach site of disease at base of pocket, be used at bactericidal concentrations, and is substantive. Now, the three types of irrigation that we know of are chlorhexidine gluconate, which is 0.12%. However, it is deactivated by blood and proteins. Then there's stannous fluoride at 0.4%, and then there's iodine at 0.05%. But you got to make sure people are not allergic to shellfish or to iodines. However, with irrigation, microbial suppression is not increased, so it does not enhance healing because the gingival clavicular fluid is replaced every 90 seconds. Either way, remember those first three things. Now, we're going to be going into healing, repair, and regeneration. This is a whole nother slide set. Moving on, so healing begins immediately after scaling and curettage. You do not want to probe SRPs until after 4 to 6 weeks of completion. Healing won't happen if biofilm is removed. Healing of the long junctional epithelium is the goal for surgical and non-surgical therapy, and it is the fastest from apical to coronal in 5 days. Connective tissue attachment is rare and is difficult. It's also minimal. Healing is the greatest 3 to 6 weeks after non-surgical periodontal therapies, while changes continue to occur up to 12 months after treatment. The soft tissues will not attach to altered cementum. So these are just little quick bullet points before we get into the meat and potatoes. Let's talk about the local factors that affect healing. We have plaque, the most common type of factor that affects healing. Foreign substances such as calculus and restorative materials like cements and bonding agents, and also trauma during procedure or healing time. So that means repetitive treatment during healing or just not following the post-op instructions. Those are factors that affect healing in a bad way. Now, systemic factors that affect healing are age, atherosclerotic vascular changes, diabetes, smoking. Smoking impairs neutrophil functions, poor nutrition, which is like lack of vitamin C and lack of protein, or malnutrition, systemic stress and hormone therapy, also a history of steroid therapy, like for arthritis, which inhibits fibroblasts. Regeneration now. Now let's talk about regeneration. So regeneration means what was there before. The professor used the examples such as like a lizard that regrows an arm. So the epithelium replaces epithelium. Now for the connective tissues, you have the PDLs, all the fibers, new attachment to cementum. That's the goal of surgical and non-surgical therapy. Again, to reattach new attachment to the cementum of the PDLs. Now for the cementum, you have cementoblasts, which are the things that create the cementum, the new cementum. New cementum is 3 weeks from PDL fibers. Not sure why I put that like that. And then also the cells that create bone are osteoblasts. Remember, osteoblasts are good, osteoclasts are bad. Okay, repair, which is wound healing. This is the main thing for repair is we want to reestablish the same level of pre-existing base of pocket. However, gain in clinical attachment is not achieved. So for repair, gain in clinical attachment is not achieved. Now, healing 1 to 2 days, bleeding if probed, white blood cells are present, migration of epithelial cells to 0.5 to 1 millimeter per day, between 1 and 2 days. 4 days, normal color on the areas of cyanosis, bleeding if probed. Epithelialization is incomplete but begins at 12 to 24 hours. That's 4 days. Now, healing to 6 to 7 days is gingival color is normal, connective tissue starts organizing, epithelialization is almost complete, little to no bleeding on probing. 10 to 14 days, tissues should be pink, keratinization continues and normally bulks up in 28 days. Now, after the 2 weeks, there still will be a histological pocket. So just part of healing slides without a number of days. So I put on there, I don't know why. There's no evidence of bleeding after 10 to 14 days. So we're talking about days after um, non-surgical therapies. Now, let's talk about repopulation of microorganisms. Generally 9 to 11 weeks, but it can take up to 6 months. So we're talking about the repopulation of good bacteria. Then there is an order of the organisms that repopulate. These go from, in this order, Streptococcus, Actinomyces, Veillonella, Bacterioides, Porphyromonas, Prevotella, and then Fusobacterium. We also need to know what dehiscence and fenestrations are. Dehiscence are when the facial aspect of the root is denuded and is exposed through the cortical bone. So it's a um, bigger manifestation. Fenestration is smaller. It's when a small facial aspect of the root is denuded and exposed through the cortical bone. So dehiscence bigger, fenestration smaller. These are when there's bone exposed through the facial buccal cortical plate, usually on the maxillary teeth. There's no clear cause for both. It's more common on anterior and facial aspects, and it can complicate periodontal surgery, and it's also prominent on root contours. Again, so let's talk about new attachments. These occur in areas of previous disease. So for new attachment, you have new PDL fibers to cementum, and you have long junctional epithelium to the tooth surface. That's new attachment. Then there's reattachment, healing of the same fibers. So trauma associated, root surface not affected by disease, and gram-negative bacteria feeds on protein. That was just probably a side note that was said during lecture. Great. So let's see how much time we got. Who knows? But let's continue, because I have one more. Let's talk about implants. All right, so there's two types of implants. There's subperiosteal, which is framework around the bone. It's an old one. Then there's endosteal, which is endosseous, inside the bone, usually one at a time per tooth. So those are the two types of implants, subperiosteal, endosteal. What is osseointegration? It's a term for direct attachment to bone from the inner titanium without intervening connective tissue. It was coined by a Swedish professor of anatomy in the 1960s by the name of Brannemark. Success rate of osseointegration is 90%. Optimal conditions to achieve it, though, means that there must be zero mobility, not even 150 micrometers, should be zero. Any sign of mobility is failure, and recommended to it's also recommended to remove the prosthesis on top of the implant once a year to test mobility, and also never use a scaler for removal, ultrasonic scaler. More other conditions to achieve osseointegration are mild inflammatory response. So it enhances bone healing, not moderate or severe. If it's too much inflammatory response, not good. The other thing for optimal conditions to achieve osseointegration is temperature during the implant placement. So the temperature has to be greater than 47 degrees Celsius. Will cause, so temperature greater, never mind, should be below. So anything greater than 47 degrees Celsius will cause necrotic bone and scar formation. Now, there's also asepsis, which is bacterial contamination. So I don't know why that is under optimal conditions to achieve osseointegration. I know optimal means good, so let's review that again. We do not want movement, no mobility, zero mobility. There should be zero mobility. Also, there should be a mild inflammatory response. And during the implant preparation, anything greater than 47 degrees Celsius will cause necrotic bone and scar formation. Now, let's talk about the implant anatomy. Peri-implant tissue means that the implant which means osseo-integrated bone to the implant. Implant anatomy again, no PDLs, cementum, and inserting fibers. Their junctional epithelium is 2 millimeters wide with 1.5 to 2 millimeters above the crest of the bone. And the supracrustal attached tissue, the biological width is 3 to 4 millimeters. Remember, supracrustal attachment is the connective tissue and the junctional epithelium. So that together equals that. So that together for an implant is 3 to 4.5 millimeters. And also there's limited vascular supply. Those are just anatomy of an implant. Just to remind you that there are no PDLs or cementum there, and there is no vascular supply except for the bone that's surrounding the implant. Now, the stages of surgery, there's 2 stages. There's a single stage and double stage. The single stage means that the healing abutment is placed at the time of implant placement. So the implant is left exposed and requires 3 to 6 months of healing time. Then the restoration can start after that. The 2 stage is the implant is placed, then they wait for 3 to 6 months for healing. Then there's an uncovery surgery that is done to place the healing abutment. And then 2 to 3 weeks later, restorations can occur. So know those 2 differences. Both require a 2-week follow-up for superficial healing. Now, so let's talk about candidates for implants. So age doesn't matter. That's what the professor said, but cannot be used on developing individuals. So that being said, people who should not get implants are people who have systemic diseases or social risk factors such as HIV, AIDS, uncontrolled diabetes, smokers, drug abusers, and people who are under high stress. Now, people who need a consultation before getting implants, I'm assuming with a physician or an oral surgeon, is if they have blood coagulation problems, if they have cancer, chemotherapy, or radiation therapy, if there's long-term steroid use, like inhaler topical steroids, if they have osteoporosis, or if they're taking bisphosphonates, if they have multiple myeloma, or if they have parafunctional habits such as bruxing and bad occlusion. So kind of similar to the implant anatomy, when compared to real teeth, you can't get cavities, you can't get root canals, and you can't get root sensitivity. And depends on proper occlusion, oral hygiene, and maintenance. There are no PDLs that lead, which means that it leads to reduced tactile sensitivity and reflex function. Implants cannot take an overload of forces, and they are not immune to biofilm. So just like teeth, biofilm control is very important, even for implants. And the same bacteria that affect teeth also affect implants. In the evaluation phase of implants, it should be done every 3 months for the first year. Then after that, yearly. You should measure the height of the bone next to the implant. X-rays need to be next to each other. Most common cause of failure is the cement. Remember that. X-rays at least once a year, and vertical bone loss of less than 0.2 millimeters yearly following the first year. Can still probe implants, but gently. Do not jeopardize the longevity of the implant. Assess bleeding, separation, cal, and X-rays. Collect initial probing depths upon seating of the implant crown. Some surgeons say no probing until 3 to 6 months. That will be dependent on the doctor. Great. So that was 3 different slide sets that I just went over with the review of the concepts of cal, the furcations, the 2 different types of periodontal probing, the plaque and biofilm formation stages 1, 2, and 3. Then we went and talked about systemic and local deliveries, antibiotics, enzyme therapy, and irrigations. After that, we talked about healing, repair, and regeneration. And then after that, we talked about implantology. Great. Hopefully this helps me out, and then maybe it'll help someone else out. Thank you for listening.